So we are live now, and I'm starting the webinar. Okay, so good evening to all respected delegates members who have joined here and faculty members who have joined here in this Core Connect virtual CME on the topic of induction of labor and clinical experience with dinoprostol vaginal insert. So in today's webinar, we are going to learn about induction of labor and also we are going to learn about dinoprostol vaginal insert. It is also called as a dinoprostone pessary or dinoprostone sustained release or controlled release system. So today we have Dr. Parag Biniwale sir. So he will be covering the topic of induction of labor and clinical experience with dinoprostone vaginal insert, where we are going to see how to use this dinoprostol vaginal insert, when to use, and how to remove, when to remove, and other aspects. So, without delaying our webinar, we will start the session. But before we start, we will start our session with digital lamp lightning session. So, be with me. Thank you so much, all respected delegate members, for patience. Now, uh, I will introduce our scientific coordinator, Dr. Amit Bhargava sir, who is also with us. So let me introduce sir. Dr. Amit Bhargava sir is currently head of Medical Corona Remedies Private Limited. Sir is also family physician at Ahmedabad, director of HEART Heart of Medicine, ex-board member, medical faculty, MUHS. Sir has also completed MBBS in 1985 and MD in 1988, both from MAMC New Delhi. And sir's professional experience is of 36 years almost, 1 year in teaching, 2 year in research at NIH Bethesda, USA, 2 year R&D and QA at Serum Institute, 2 year of IT industry, 10 years of clinical practice in Baroda, Mumbai and Ahmedabad, and 28 years of experience in pharma companies like Alembic, Alchem, Cadila, Elder, Glenmark, Lupin, and Sun Pharma. So I welcome sir, Dr. Amit Bhargava sir, and I hand over session to Dr. Amit Bhargava sir to take further.
Thank you very much, Nilesh, and a very warm welcome to all of you who have taken the time out to join here. And I know this is kind of a very busy time from the practice point of view, and yet you're here, so welcome. I would also like to welcome Dr. Biniwale. Before I hand over the session to him, I have a few slides just to illustrate to you why at Corona Remedies we have these kind of meetings. I will not take up much of your time from the main agenda. So just give me a minute. I will share the slides and then we will be set to go. Okay, here we go. Okay. All right, here we go. So a very warm welcome from Corona Remedies. Why these meetings? Very simple, from a very practical point of view. It's all about the interlink between clinical practice, clinical reasoning, and the most important factor, clinical experience. So we have all been through this professional lifespan spectrum. We have been students, we have acquired knowledge, we have become professionals, we have practiced, become successful, and some, like Dr. Biniwale here, have got exceptional clinical experience by virtue of which they are proclaimed as experts. So there is a need to share these experiences by the experts so that the ultimate outcomes in the clinical practice of all of us improves. So that's the whole objective why we have these meetings. Now, this clinical practice spectrum has also undergone a change. Typically, once upon a time, I mean, every meeting you go to, it was evidence-based medicine, etc., etc. But today we realize that RCTs and guidelines are not enough for clinical practice. They're not good enough. So the world has moved on to this concept of clinical reasoning, which is not to do away with the importance of RCTs and guidelines. They are very much absolutely integral and important parts, but there is something more. And that has been very nicely summarized by Professor Schneiderman from Mayo Clinics in one of the articles. I mean, there are a number of them on clinical reasoning, but this is one of them. And what he says is that these are all the modalities that we rely on for doing our practice, guidelines, RCTs, observational studies, investigator-initiated studies. All these are important and they provide valuable data. But we need mechanistic reasoning. What is exactly happening in that single patient sitting across the table? We are not doing a trial in clinical practice. There is one patient across the table and we have to figure out what's going on. And most important is the clinical experience. This entire gamut is what is referred to as clinical reasoning. Now, in this, all these elements that you see here, the guidelines, RCTs, etc., they are available in public domain. Everybody from a postgraduate to the greatest of experts has read them. They're all static evidences and what I call them as contrived because they have been designed. They're not real. Whereas the clinical experience component is something which is unique, intrinsic, integral, and dynamic. It keeps changing from time to time, and we keep learning more and more. So experience, clinical experience becomes a very important tool in our day-to-day clinical practice. So clinical evidence plus, I'm not downplaying clinical evidence, please mind. The guidelines and RCTs remain absolutely important. But for clinical practice, if we have clinical experience, that is what makes a person a clinical expert. And we have one such expert with us today, Dr. Biniwala. He is a highly accomplished person. He has held a lot of positions, currently chairman, elect Indian College of Obs and Gynae. He has been president, editor, peer reviewer, and chairman of Young Talent Promotion Committee also, and all for a number of years. In addition, he has been a superlative academician also with several articles in journals and books. He has been co-editor in multiple books, delivered orations and guest lectures in more than 160 Foxy meetings, and recipient of Best Paper Awards at various meetings. So it's our privilege to have him here and hear about his experiences on induction of labor with benefits for all three. What do I mean by all three? The three key participants, the mother-to-be, the fetus/neonate, and the obstetrician. So this is something which is going to benefit all the three participants of this exercise of IOL. And that entity today is, as Nimesh has already told you, is Cervidil, the latest, safest, fastest, simplest in the evolution of IOL options. I mean, I'm not promoting it. It's just that from the beginning till the end, I mean, all therapies evolve. And Cervidil is also probably not going to be the best. In times to come, there will be things better than this. But as of now, it seems to provide a lot of benefits, which Dr. Biniwala will so I will stop sharing and hand over the session to you, sir.
Thank you, Dr. Bhargav, for those kind words. Good evening. I bring greetings from a very hot city of Pune. The temperature is 42 degrees and somehow the electricity is also playing havoc here. So, Nilesh, it may so happen that the electricity may just go off and then I'll log in from my mobile and ask you to share the presentation if need arises.
No problem, sir.
All right. So, in next about 45 minutes, we are going to talk about one very important aspect of obstetrics, and that is induction of labor. And I must say that all the obstetricians who are listening to it, do visit the ICOG website. We have done a lot of work and we've created guidelines on induction of labor, which are very much there on the ICOG website, and a lot of information even about the dinoprosone vaginal insert will be found in the induction of labor because it definitely has its own place. Like Bhargav, I come from an era where prostaglandins were not available. So for us, induction of labor was all about mechanical methods like doing an ARM or doing a sweeping of membranes. We did use oxytocin for ripening of cervix, but in the mid 90s, when the prostaglandins came in, our labor management changed. We were better equipped when we were thinking of inducing labor. I remember good old days where we used to induce patients almost for 2 days with oxytocin, hoping for them to go in labor. But now, with the advent of prostaglandins, initially gel, tablets, and now insert, we are much better equipped in managing induction of labor. So all of us know that labor is a process which is characterized by regular, frequent, and effective uterine contractions. And along with these contractions, there has to be a dilatation of cervix, which takes place at the rate of 1 to 2 centimeters per hour. So the dilatation of the cervix has to be progressive. Of course, there is effacement, which is so important when we think of labor. And at the same time, the descent of the fetal head is extremely important in order to achieve a vaginal birth. So when we talk about labor, we typically talk about 3 stages. And of course, nowadays we talk about the 4th stage also. The first stage is characterized by initiation of labor process. So once there is onset of labor till full dilatation of cervix. So there is latent phase, active phase, and descent. And the WHO has come up with a lot of new evidences and guidelines about the first stage of labor. The second stage of labor is from the full dilatation of cervix until delivery of the baby. And this is something which is so very important because the time duration also now has changed. In a primary gravid patient, we always used to say that more than 1 hour of full dilatation was prolongation of second stage of labor. But now 2 hours is a norm. And if the woman is under epidural, we can also wait for up to 3 hours of second stage of labor. Third stage is again something which is extremely important, in which the delivery of the placenta takes place, because this is the time where postpartum hemorrhage sets in, and we are still losing a lot of mothers because of postpartum hemorrhage these days. And of course, the fourth stage, as labeled by some, is when the 2 hours after the placenta comes out is called as the fourth stage, because again, vigilant monitoring is needed even in these 2 hours of time. So when we talk about onset of labor, there are few factors which are responsible. The first and foremost are the mechanical factors, the uterine distension, stretching of the lower uterine segment. So typically, when the fetal head starts descending, it does stretch a lower uterine segment, and of course, along with it, softening of cervix or ripening of cervix or taking up of cervix, that is cervical effacement. There are quite a few hormones which are involved in this process. So withdrawal of progesterone is something which is so important. Prostaglandins do have a lot of role to play in changing the characteristic of the cervix, and oxytocin also has some role, though we know that oxytocin may not be involved in initiation of labor, but it does contribute to the progress of labor and essentially in parturition of the fetus. So when we think of cervical ripening, so initially, especially in the primigravida, there would be thinning of the cervix called effacement. And we can do a clinical examination and judge how the cervix has effaced. So a cervix which is thick, firm, starts becoming soft, it starts becoming pliable. So typically, in a primigravid patient, there would be thinning of the cervix, that is, the effacement would start first, and then the cervical dilatation will start, which will help in progression of labor in due course of time. So when we talk about cervical ripening, we must understand these two phases. The first phase is a slow phase where the collagen fibers get reorganized, and second is the rapid phase where the collagenase dissolution takes place by collagenase and elastase. So there is a slow phase and then there is a rapid phase, and rapid phase is the one where there would be dilatation and effacement. And of course, there are certain mediators for transition to rapid phase, and these include prostaglandins. Of course, there are some inflammatory mediators. There would be reduction in progesterone levels, increase in estrogen and relaxin, and all these will help in ripening of the cervix and then eventually initiation of labor. Coming to induction of labor. Now, induction of labor is something where we are artificially initiating the process of labor. So whenever there is a certain risk to the mother or the fetus associated with continuation of pregnancy, we always weigh it with the maternal and fetal risk vis-a-vis induced delivery and then decide whether a particular woman requires initiation of labor or induction of labor. So why induction? Induction of labor will help, and there is good evidence to talk about it. Unnecessary cesarean deliveries, especially in prolonged pregnancies beyond term, or women who come to us with pre-labor rupture of membranes, and if they do not go in labor, it is prudent that we think of inducing labor. So labor induction is recommended primarily whenever there is a concern about the health of a mother or a baby. And then there are multiple indications for induction of labor. Let's first see the indications and then think about contraindications. Reliable estimation of gestational age. So the WHO says that we can certainly wait beyond 40 weeks, plus minus 7 days, or even they say that up to 41 to 42 weeks. But in reality, we obstetricians do not prefer to wait beyond the gestation of 40 weeks. PROM term or even pre-labor rupture of membranes or even premature rupture of membranes, where we would certainly like to induce a labor. And the RCOG and ACOG also talk about other conditions, which include intrauterine fetal demise, previous cesarean section. Of course, the decision has to be an individual based, and even maternal requests. Some women do ask for induction of labor on a particular day. But typically, the induction would include conditions like maternal hypertension, preeclampsia or eclampsia, maternal medical condition, and in our country, gestational diabetes mellitus is one very important situations where induction of labor is done. If there is fetal growth restriction, fetal demise, we would certainly like to induce these labor, and situations where there is chorioamnionitis or abruption of placenta, we would certainly induce the labor rather than to prevent any kind of eventualities. Of course, there are certain contraindications to this. So any abnormal presentation, so for a breech or for a transverse lie, we will certainly not induce a labor. If there is vasa previa or complete placenta previa, umbilical cord prolapse, genital herpes infection, again, it has now become an indication for C-section, previous myomectomy, and previous classical cesarean section, induction of labor is something which is not recommended. So the FOXI GCPR, which was published in 2018, talks about induction of indications for induction of labor as commonly hypertensive disorders in pregnancy, maternal conditions like diabetes, kidney disease, pulmonary disease, fetal compromise, pre-labor rupture of membranes, fetal demise, and prolonged pregnancy. Of course, the relative contraindications remain more or less the same. We have to keep in mind that if there is risk of rapid labor, we would rather keep the patient admitted or induce her in order to prevent any unwanted mishaps. So we also know that induction of labor can improve the perinatal outcomes. Now, this was a study which was published in 2012 in the Cochrane database, and which talks about expectant management vis-a-vis labor induction and how it has impacted on perinatal deaths. So if you look at the slide very, very carefully, we know that induction of labor at a right time definitely helps in preventing certain perinatal deaths. So as compared to the expectant management, induction of labor was associated with lower risk of fetal demise and admission to NICU. So in general, the risk of adverse outcome with labor induction was better than the expectant management. And the different methods of induction of labor were also found out. And it was finally concluded that induction of labor does reduce cesarean section rate. And here, especially if we are waiting for certain situations where we want the woman to go in labor, we now know that induction of labor is generally associated with a better chance of having a vaginal delivery or vaginal birth as compared to a cesarean birth. So this is a meta-analysis which was published in 2014, which talks about the risk of cesarean was lower amongst women whose labor was induced than women who were managed expectantly, especially in the postterm. Now, whenever we are dealing with a woman who is post-dated, that is beyond 40 weeks, we are always concerned about the fetal health. We are really not sure about the meconium staining of Leica. We really are not sure about the fetal risk in general. And in this situation, vaginal induction of labor does work well in some situations. Now, there are complications associated with postterm pregnancy and cesarean section deliveries. Now, here we have to understand that whenever we are dealing with a postterm pregnancy, they are at a higher risk of having C-section. Generally, these babies are big, and women may land up with perineal lacerations. So endometritis, choriamnionitis, and risk of postpartum hemorrhage is known in this. As far as the fetus or the neonate is concerned, the fetal heart rate abnormalities, meconium staining and aspiration leads to increased neonatal and perinatal morbidity and mortality. Sometimes babies who have macrosomia do land up with certain complications, and let's not forget the neonatal acidosis and neurological complications. Similarly, there are certain issues with C-section in these patients because they are at higher risk of thromboembolism. PPH with or without hysterectomy is a known entity. Possibility of uterine rupture, wound hematoma, endometritis, urinary infection, etc. are known. And here we are always concerned about the perinatal morbidity and mortality, and the baby faces challenges after the baby is born. There are multiple factors which are implicated in the success of labor. So it is not only the drug, but there are so many factors which we have to take into account before we think of inducing a labor. First and foremost is maternal age. 30 years ago, when I started working, The average maternal age was around 25 to 30. Now, over these years, we do have a lot of women beyond the age of 35, which do plan to become pregnant, and they are the ones who are going to face labor tomorrow. So increased maternal age again is probably something which is adding a woo to the process of labor. Parity. Multiparous woman, of course, there are better chances that she can go in labor on her own. In a primary gravid patients, it always takes a while. Of course, Bishop score will tell us how how successful the induction will take place. The indication of induction is again important, because if the baby is jeopardized, we have to have a low threshold whenever we are thinking of inducing labor. Of course, obstetric history, body mass index, because we do get to see a lot of obese and overweight women, which again have a problem of macrosomia and gestational diabetes associated with it, and then the success of induction of labor is hampered at times. So all these factors have to be taken into consideration when we think of induction of labor. So cervical ripening is a very, very important process for induction of labor. So wherever we have a cervix which is favorable, the induction would be rather successful than unfavorable cervix. Now, how do we deal with an unfavorable cervix? So here we have to stimulate the cervix artificially. And how can we do that? There are, of course, some non-pharmacological methods, right from castor oil, which was given in good old days, to mechanical procedures like Foley's catheter, and now the pharmacological methods, which are easy to administer with not many side effects and more or less ensure a good, successful outcome. So Bishop score is something which is so dear to all of us obstetricians. We know that when we think about a labor, the first thing that comes in mind is about the modified Bishop score. So here we are taking into consideration the cervical dilatation, the length of the cervix, which means the effacement of cervix, station of the presenting part related to the ischial spines. So we always say it in -3 to -1 to 0 to +2. Consistency of the cervix, softer the cervix, better is the cervical score. And similarly, the position of the cervix. Typically, the cervix is supposed to be positioned posteriorly, and as the due date comes closer, we expect the cervix to move anteriorly or be mid-pose. Now, the Federation also has added few points, because these are some modifiers which are really important when we are thinking of inducing labor. Now, here there are some points to be added, especially for preeclampsia or with each previous delivery. This would add to a better outcome. And then if we are dealing with a post-date pregnancy or a nulliparous woman or a woman who has pre-labor premature rupture of membranes, we need to subtract 1 point. So here the Bishop score may not be as applicable or may not be as appropriate as the modified Bishop score says. Now, coming to the clinical experience with dinoprostone vaginal insert. As I said, about nearly 29-30 years ago, prostaglandins were introduced in the Indian market, and then they have been game changers since then. So we are going to talk about especially the dinoprostone vaginal insert. Now, this is something which is important in initiation or continuation of cervical ripening in patients at or near term in whom there is a medical or obstetric indication for induction of labor. The drug, of course, is PGE2 in the dose of 10 milligrams, and it is in a reservoir in the form of a vaginal delivery system. And there is controlled release of this particular drug, which is released in the dose of 0.3 milligrams per hour. So since this is a controlled release preparation, the drug is maintained throughout the dosing period, and that is up to 24 hours. And half-life of the drug is 1 to 3 minutes, and it is really important for us to know this, because if we land up with hyperstimulation, we just have to remove this insert, and then things will settle down in next 1 to 3 minutes. But it is really important for us to store this particular system very, very properly, and it has to be stored in a freezer in the original container to make sure that the potency of the drug remains more or less the same. So this is how the dinoprostone vaginal insert looks. So it is 10 milligrams of dinoprostone dispersed in a hydrogel matrix. It's a simple insertion to start treatment. I'll talk about the insertion in a bit. And a single insert delivers controlled release of drug at the cervix for up to 24 hours. It means that once you insert the device, we have to be very, very patient and then keep the system there for 24 hours in order to achieve a vaginal birth. And then there is a long tape retrieval system which allows immediate removal if required. So this is how the insert will look. So there would be a hydrogel polymer matrix delivery system. After insertion, the insert absorbs vaginal moist and fluid, and it swells to 2 to 3 times its original size, and then it starts releasing PGE2 continuously at the rate of 0.3 milligrams per hour. So in general, it is 7 milligrams of PGE2 is released from the vaginal insert during administration. So how do we do it? Open the aluminum foil. You can have a look at the slide and then see how this particular system is available. So till you decide to insert it, keep it in the freezer, and then directly it is brought to the labor room or consulting room where you're going to put this. So once you open it, pull out the DVI vaginal delivery system using retrieval tape, position the insert securely between 2 fingers, and we obstetricians and gynecologists are very well versed with using these 2 fingers, and this is how you catch it. Introduce it gently high up in the vagina, and if we may take help of a lubricant gel, and the device has to be positioned behind the cervix in the posterior vaginal fornix in order to make sure that it remains in situ. So it has to be placed transversely, and this is really important because proper administration will avoid potential risks. So it should be done by a trained personnel, and I'm sure in the insert there are pictures given how to insert this particular device. Now, how do we remove it? We can just pull the tape or the retrieval cord gently, and it comes out very, very easily. And after removal, we must wait for at least 30 minutes before starting oxytocin if we feel that the contractions are not adequate. So what are the reasons for removal? Now, if there is insufficient cervical ripening in 24 hours, now once the woman goes in labor, so if there is onset of labor, or I should say active labor, if there is uterine hyperstimulation, we must remove it immediately. There was a time we used to say that once the membranes are ruptured, we should remove this device. Not anymore. Even if we are dealing with a woman with PROM, or even if the membranes are ruptured spontaneously, we can still keep the device and be very, very vigilant. If there are any maternal adverse events, or if there is evidence of fetal distress, we just have to remove the insert immediately. And this is the advantage of dinoprostone vaginal insert over the gel, because if there is hyperstimulation or if there is fetal distress, we cannot retrieve the gel, but the insert can be removed immediately, and then things can be settled in next 1 to 3 minutes. Coming to the efficacy. Now, there were quite a few studies which compared the dinoprostone vaginal insert versus expectant management versus placebo. And what they found out was treatment success was considered as the Bishop score increased at 12 hours of more than 3, or Bishop score that 12 hours of more than 6, or active labor or vaginal delivery within 12 hours. So here we also have to remember that some women may take a little longer time. So we really have to be patient and for 24 hours and observe the woman very, very carefully. So in a retrospective study here, if you look at the slide very carefully, we realize that in multiparous women, more labors take place earlier as compared to nulliparous women, and the mean time to cervical ripening was much faster in the multiparous women. And then if you look at the slide carefully, most of the women, especially almost 93% women, did have a better ripening within 24 hours, and almost 75% women did have cervical ripening within a span of 24 hours. So nulliparous and multiparous women were grouped in the presented trial. However, the time of onset of labor remained statistically different between the DVI and placebo groups in primiparous women. So here there was a faster initiation of labor as compared to placebo even in the primary gravid patients. And this is a retrospective study where majority of the patient, almost 69% of them, went in active labor within 24 hours of insertion of dinoprostone vaginal insert, and induction to delivery interval was significantly influenced by parity. Of course, we would expect more nulliparous women to deliver within 24 hours as compared to nulliparous women. So when we talk about induction of labor with DVI, so one application in majority of the women is important and it is useful. The second application, if you ask me personally, in about 40 or 50 patients that we've used all these years, we've not used insert for the second time. We've used only one insert and then observed the women for 24 hours. We personally believe, though there is literature which talks about second insert, if the cervix remains more or less unchanged after insert of or after observation of 24 hours of dinoprostone vaginal insert, which rarely happens, most of the patients do go in labor with the dinoprostone vaginal insert. But if one insert doesn't work, there's hardly any advantage of using the second, because it may not give us the desired benefit. Now, comparing DVI versus mechanical methods, and here there are Foley's catheter which are used for ripening of cervix, and of course there are some people who've used double balloon catheter as well. So this is a study where Foley's catheter and DVI were compared, and of course the cesarean deliveries were less in the vaginal insert group. Spontaneous deliveries were also more in the Foley's group, of course, and the time from start of intervention to birth was more or less same. There was a slight advantage with the DVI. So DVI generally results in a lower rate of oxytocin augmentation compared with Foley's catheter. Now here we have to remember that cervix does get ripened with mechanical methods, but the contractions generally are not initiated, where the prostaglandin insert will also help in initiation of contractions, and then the requirement of oxytocin may not be as much. So when compared to the Foley's catheter and dinoprostone, it was found out that there was a mean difference of about 5.73 hours in induction to delivery interval. And these 6 RCTs found that comparable cesarean section rates in women who were randomized to dinoprostone vaginal inserts vis-a-vis Foley's catheter. And this is again another meta-analysis of 5 RCTs, which found that dinoprostone and Foley's catheter and dinoprostone had comparable vaginal delivery rates. Of course, we can see more number of women delivering with the dinoprostone gel. When compared to the double balloon catheter, what was found out was DVI did in almost 50% women, they were able to achieve vaginal delivery within 24 hours, whereas the double balloon catheter took much longer. C-section rate was slightly higher in DVI group, not significant, and a need of epidural analgesia was of course noted for women who had opted for double balloon catheter, and probably this was because of the longer duration of pain that they were going through. And of course, the overall vaginal delivery rate was a little better with dinoprostone vaginal insert. So oxytocin requirement, as I said earlier, is definitely much less when we are using oxytocin. And even in this particular group, the need of oxytocin was less for women in whom induction of labor was carried out with dinoprostone vaginal insert. And the vaginal delivery within 24 hours was noted in almost 53% as compared to 50% women who had double balloon catheter. But what was more interesting in this particular study of 2015 was that the C-section rate was much less as compared to the double balloon catheter when used in almost 155 women. Now, this is one more trial which was published in 2014, which studied the mean induction delivery time. Then when compared to the double balloon catheter, it was found out that the time from induction delivery was within 24 hours was noted in about 47% women, vaginal deliveries in about 48% as compared to 45.2%, and C-sections were slightly less as compared to the double balloon catheter. Now, what about other prostaglandins? How does DVI fare as compared to the PGE2 gel, Mesodyl, and oral misoprostol? Now, when we compare to the PGE2 gel, we realize that the DVI works better and it definitely has better chances of vaginal delivery as compared to the PGE2 gel. Mind well, PGE2 gel, the dose is a little less. We can repeat it every 6 hours if needed, but generally we do not advocate more than 3 doses. Here, we are delivering a system where the drug is released slowly in much higher doses of PGE2 gel without causing any reasonable or unreasonable side effects of the drug. So comparable C-section rates were seen with PGE2 gel and DVI. Coming to oral misoprostol, now oral misoprostol is something which I personally do not use much. I am happy with prostaglandin vaginal gel and vaginal inserts. Now, this was an RCT conducted in Saudi Arabia in 2014. And what they found out was the DVI was associated with a lower rate of vaginal delivery in 24 hours as compared to the oral misoprostol. So the RCT of 160 women conducted in Saudi Arabia, time from first treatment to vaginal birth was very much comparable, DVI versus oral misoprostol. The induction to delivery time was a little shorter with vaginal insert, and vaginal delivery within 12 hours was achieved in more number of women who received dinoprostone vaginal insert. So whenever there is a new system, we are always concerned about the safety. Now, one of the commonest complications of induction of labor, especially with prostaglandins, is uterine hyperstimulation. We know that uterine hyperstimulation is overactivity of the uterus, and this can be defined as a uterine tachysystole, where there are more than 5 contractions in 10 minutes, lasting for about 30, lasting for about 30 minutes or so. Or there is uterine hypertonicity or hypersystole, where the contraction itself is lasting for about 2 minutes. So it may or may not be associated with changes in fetal heart rate pattern, like persistent decelerations, tachycardia, and decreased short-term variability. An increased risk of uterine tachysystole is expected complication associated with induction of labor with oxytocin, dinoprostrone, and misoprostol. So typically, whenever we are inducing any labor with prostaglandin, we always observe the patient for about 30 to 45 minutes continuously, because this is the time where uterine hyperstimulation, especially in the form of tachysystole, is likely to be better. So even if there is tachysystole, if it does not have any impact on the fetal heart rate pattern, it is safe. But if there is tachysystole and if there are associated FHR changes, we really have to be concerned. So a deceleration of fetal heart rate in response to contraction has been shown to be more indicative of neonatal depression or metabolic acidemia than the rate of contraction alone. So we always have to equate the contractions and see the relationship of contraction and fetal heart rate, and we must see whether there is presence or absence of fetal heart rate decelerations. Little bit about the FHR tracing categories. So typically a normal tracing would be the baseline heart rate is normal, the fetal heart rate variability is normal, and how do we interpret it? So it is strongly predictive of normal fetal acid base status at the time of observation, and these women should be monitored as a routine cases. There's no specific action that is required. The second is intermediate, where there could be baseline tachycardia, but it is not accompanied by baseline change in baseline variability or tachycardia. Baseline FHR variability may be present or absent with no recurrent decelerations. There could be an absence of induced accelerations after fetal stimulation, because once you stimulate the fetus, we expect the fetal heart rate to increase, and that is a reassuring status for us obstetricians. Or in the intermediate tracing is where there is periodic or episodic decelerations. Now, we have to remember that this is not predictive of abnormal fetal acid base status. It does require evaluations, continuous surveillance, and these patients have to be reevaluated periodically, and we have to correlate it with clinical circumstances and then take the best possible decision for the woman. And the third is abnormal. Now, when we say that there is abnormal fetal heart rate tracing, there is absence of baseline variability, or there could be recurrent late decelerations, recurrent variable decelerations, and bradycardia, or there could be sinusoidal pattern. All these indicate that there is abnormal fetal acid base status. It requires prompt evaluation. We have to do the measures to resolve abnormal fetal heart pattern, and if they are not resolved, delivery should be undertaken as soon as possible. Now, let's just see some preclinical studies, and they have demonstrated safety of the dinoprostrone vaginal inserts. Now, the preclinical studies have demonstrated that PGE2, the acting ingredient of the DVI, acts locally, has no significant systemic exposure, and no evidence of toxicity. So all these points reassure us that it is a safe drug to be used for induction of labor. Similarly, the hydrogel polyurethane and polyester polymers, which form part of a release method of PGE2 and the retrieval device, have showed no adverse effect in toxicity studies. were found to have no local tolerance problem, because again, this is something which we are worried about. If you are inserting something in the vagina, it shouldn't cause local irritation or even discomfort to the patient. And the hydrogel was negative when tested for causing toxic shock syndrome, because this is something which has been studied in women who use tampons during menstruation. So we are always concerned about the toxic shock syndrome. So DVI also has demonstrated in clinical trials the safety profile. Firstly, hyperstimulation rates are low and they are reversible. So in this particular study, the hyperstimulation was less than 5%, and all reversed within 2 to 13 minutes of DVI removal. Only one patient required tocolysis to resolve hyperstimulation. In our own practice, in one of the patients, we did have hyperstimulation, and she went into precipitate labor. After insertion of the insert, she started getting contraction, and to our utter surprise, she delivered within next 2 hours from the Bishop score, which was extremely unfavorable. And within 2 hours, she just delivered. Luckily, the mother and the baby did not have any challenges. Now, whenever we are applying any system for induction of labor, we are always concerned about the neonatal complications. And there are quite a few studies which talk about its safety as far as the neonates are concerned, and the reported Apgar scores of 7 or above. So DVI is generally well tolerated with low incidence of uterine hyperstimulation as compared to placebo. Now, of course, we know that whenever we are using a placebo, there cannot be any hyperstimulation or there cannot be fetal distress. But if you look at the hyperstimulation that was caused by the DVI, it was quite negligible. DVI also has comparable low uterine hyperstimulation rates compared to Foley's catheter, but it was associated with higher rates versus the double balloon catheter. Now, if you look at this particular slide carefully, now women who where double balloon catheter were used did not have any chance of hyperstimulation, and this was almost nearing 10% with the dinoprostone vaginal insert, and it was statistically significant. The DVI and oral misoprostol do demonstrate a largely favorable safety outcomes. Now, the frequencies of maternal adverse events were similar in both the groups, which included non-reassuring FHR, which was higher in the DVI group rather than oral misoprostol group, although the NICU admissions were lower with women who received DVI. Coming to the safety profiles, if you look at the maternal outcomes like tachysystole or hyperstimulation, they were little more in women who received DVI, and even the neonatal outcomes were little better with oral misoprostol as compared to DVI. Now, DVI demonstrates a faster resolution of tachysystole following retrieval compared to Mesodel. Now, unfortunately, Mesodel is something which is not available here, but this particular study in 2017 did compare DVI versus Mesodel, and what they found out was the intrapartum or uterine tachysystole was much higher, or even changes in FHR pattern were much higher with Mesodel as compared to the DVI. The adverse event leading to retrieval was much earlier in women who received Mesodel. And of course, the adverse events were after the insert to the resolution of adverse event was much faster, or relief of uterine tachysystole was much faster in DVI as compared to Mesodel. So DVI in general is well tolerated and associated with a lower incidence of tachysystole than Mesodel. Post-marketing studies, we always are concerned about pain. Now, even in our personal experience, we realized that the DVI is responsible for less pain as compared to the vaginal PGE2 gel. Of course, we do have very safe and effective methods for pain relief, but in general, the need of analgesia requirement is generally less with DVI. So to conclude, these are some of the terminologies that we've used. And of course, thank you very much, Team Corona, and I would be very happy to take any questions if there are.
Thank you very much, Dr. Beniwale. That was very nice, short and lucid description, and clearly highlighting the benefits of the DVI. Now that it is available here, possibly there will be a greater usage, and the Indian experience with the DVI will come forth more in times to come. Nilesh, have you got any questions? I have some.
Yes, sir. One question is arriving. One doctor wants to know how the gel administration is means difference as compared to our dinoprostone insert. Means the question is that doctor is confused that gel is used in intracervical or what is the difference between gels insertion and dinoprostone insertion?
Okay. Now, basically, we know that the gel comes in a pre-filled syringe. Now,
Yes.
we have to take the patient to the labor room, give her lithotomy position, rotate the cervix, and then we need to instill this particular gel in the cervix. Now, there are few consultants who believe that rather than intracervical, the application should be vaginal, but there are a lot of studies which are available which talk about this controversy. I personally prefer whenever we are using gel, we use it as an intracervical installation because that is what is meant for, and it definitely acts on the cervix better. The intravaginal administration, which is generally done, the syringe is emptied in the posterior fornix, and then we hope that it works the same way as the intracervical installation. But it doesn't. The vaginal administration is a little bit erratic as compared to the intracervical. Now, whenever we are using the insert, it has to be inserted in the posterior fornix. It has to be placed behind the cervix. And what we do is we try and, just put that tape around the cervix to begin with so that it stays where it is supposed to be. Now, main difference between gel and the insert is number one about the dose. The dose of the gel is much less as compared to the insert. Insert is giving 10 milligrams, and here they are giving only 2 milligrams of dinoprostone. Second thing is once we instill the gel, it starts acting immediately. So there are higher chances of tachysystole. There are higher chances of even hyperstimulation in general. As compared to this, the inserts are much gentler because at a given time, the dose that is released is only 0.3 milligrams. So it is definitely more friendly as far as the uterus and the cervix is concerned.
Okay, thank you, sir. Another question is that in how many hours this dinoprostone vaginal insert can deliver or cause the induction of labor in your clinical experience for
Okay.
nulliparous woman as well as for multiparous woman?
Right. So honestly, we've used it in nulliparous women where the Bishop score was very, very poor. And in these women, we were very sure that single application of gel will not suffice. So we have used the insert primarily in these women because here, you have to be really patient when you are monitoring these women, because once you insert it, you just have to sit with the patient for next 24 hours doing nothing. Right? It doesn't mean that the patient should be allowed to go home. The patient is hospitalized. She has to be monitored closely. And then if she goes in active labor, then we reassess her and then take a call whether the insert should be removed or not. Because many a times it so happens that if the cervical dilatation is, say, about 4 or 5 centimeters, if the membranes are ruptured, then you may not require the gel to, or you may not require the insert to be in place, and then we can remove it and the labor progresses very nicely.
So, sir, in how many hours does it
It
take?
depends. It depends on case to case. So, but for 20, this is a principle we have to understand, that we should not do any intervention for 24 hours. We have to allow some time for the patient to go in labor on her own. So typically, what we have noted is generally the cervical changes start taking place in about 12 hours. Many times our patients did deliver anywhere between 12 to 18 hours. But I personally believe that in women, I think out of these 40 or 50, in about 3 or 4, after 24 hours, there was hardly any change in the cervix. And then we counseled the patient and then decided to take them up for C-section. I personally believe that whenever we are using this particular method, counseling is extremely important, because once the patient is admitted, the relatives are in a hurry कि अभी डिलीवरी कब होगी, बच्चा कब आएगा. So you have to tell them that you have started the process and you are just going to wait and see how it is going to help the woman achieving a vaginal birth. Because see, whenever we are inducing a labor, we also intend to have a vaginal birth, and in our experience, vaginal insert has a better chance of patient landing up in a vaginal birth as compared to misoprostol, or even as compared to prostaglandin gel.
Okay, sir. Yes, sir. These were the question from my side. Is there any question, Dr. Amit, sir? Sir, you are muted. Amit, sir, you are muted.
Sorry. People like me should always remain muted.
You have such a
Okay,
vast experience, so you can also give your comments about the model.
Okay. See, I mean, this question has come previously also, it has come today also. It comes with anything new that comes in the market. Cost.
Yeah.
Misoprostol is so cheap, this is so expensive. But, I mean, previously I would leave it to the expert. But so before you give your answer, I just want to add a little perspective here, that let us not compare entity to entity costs. That's a very childish way of looking at it. The greater benefit that we're giving to the patient by reducing the chances of tachysystole, cesarean, etc., and not to mention the benefit to the fetus, less NICU admissions and all. All these things also cost money. And if you use a cheaper option like misoprostol, then your cost equation becomes few rupees plus several thousand or lakhs. Whereas with the dinoprostone vaginal delivery system, it is a few thousand plus possibly nothing. So while that counseling happens, we should counsel the patient about the prospects of saving on the complication cost. At the same time, of course, if the patient is really needy, cannot afford anything, then we have no choice but to go for the really cheap option. So, sir, over to you.
Yeah. Okay, Dr. Amit, you brought out a very, very valid point. Now, I personally work primarily in private sector, right? So I have used dinoprostone vaginal insert in my private practice. Now, when we used this particular molecule almost about 15, 16 years ago, when it was Cervidil, in fact, was introduced first, incidentally, I happened to be part of the ad board at that time. And the cost of the system then about 16, 17 years ago was around 5,700. So that was a huge cost as compared to 500 rupees of prostaglandin vaginal gel. So whenever we were discussing this, whenever we were counseling women, stating that, this is something which is expensive and which we are going to use it because we are hopeful that you will be able to achieve vaginal delivery. There are better chances as compared to the conventional methods. We were very, very transparent on this. So even now, whenever we are counseling a patient or whenever we are admitting a patient for induction of labor, we tell them that, see, your cervix, the cervical character is absolutely poor. So the Bishop score is poor. So the chances of gel acting on it in order to achieve a successful labor and a possible vaginal birth are much less as compared to the dinoprostone vaginal insert. And then now, of course, it is almost half the price of what it was about 15, 17 years ago. So it still works very well. So we do make patients aware about the cost as well, but we also highlight the benefits because this is what we have experienced in our own practice, where in about 40 or 50 women where we were able to achieve almost 90% vaginal deliveries and only 10% of them did require a C-section. I know that it is not a huge number, so we cannot, publish a paper on it, but this is the our own clinical practice that we have carried out over all these years.
Yeah, I think that makes the thing quite clear. So one little question that has come up, it's kind of not related to IOL. Is it somebody has read some studies about using these options for IUCD insertion because they help with the reduction in the pain and the subsequent insertion of the IUCD through the cervix into the uterus. And yeah, I mean, is there any merit to this?
I see, honestly, whenever we are using any intrauterine, whenever we are contemplating insertion of intrauterine device, we are preferring misoprostol in these women, and this is what our standard practice is. At least 1 to 2 hours before the procedure, we give a 200 milligrams of misoprostol either buccally or vaginally, and then that works wonderfully well. And it's much cheaper because, see, dinoprostone would act better, but then we are talking about a gynec cervix. So we really don't know how well it will act on a gynec cervix. For a patient whose term or near term, this would be the better option because the cervical character changes. But then again, here we are waiting for 24 hours. Now, for IUD insertion, you possibly cannot put an insert, ask the patient to report the next day. It's not worth the effort. Because, many a times there was a time when misoprostol was not available, or we were not using misoprostol regularly to ripen the cervix before the IUD insertion. We always used to put the IUDs like that. So we didn't even bother about ripening the cervix. If needed, we use local anesthesia and then dilated the cervix to about 3 or 4 and then have inserted the IUDs. So this becomes too far-fetched for IUD insertion.
Understood.
One more question is there. I don't know it is relevant or not, but one doctor is asking that can it be used in fetal demise, premature fetal demise?
In fetal demise, we can certainly use it, but here again, we have to counsel the patient that we really have to be patient, and we can definitely use it in fetal demise.
Okay.
But it is, see, again, as far as fetal demise is concerned, right now the protocol that we are following is we first give mifepristone, and then after about 36 hours, we admit the patient. We are using mechanical method, that is, we are putting the Foley's catheter inside extra amniotically and then inflate it using 50 cc of normal saline or water for injection. And then after 48 hours, so that is 12 hours after we insert the Foley's catheter, we start misoprostol in the dose of 200 to 400 milligrams every 6 hourly, either buccally or vaginally. And then we are able to deliver these patients within, say, 6 hours or even earlier of using misoprostol. So again, this becomes little expensive, I should say, or little time consuming. But here, for or premature intrauterine devices where the IUD has taken place at, say, 24, 28, 26 weeks, the method which we are following works really better. But then if there is an unfortunate scene where we have an IUD near term, I would certainly prefer Cervidil rather than other methods. Because again, it will be more gentle to the cervix.
Right.
Thanks.
So before we, there's one little question that I had based on a discussion that I had with an expert like you. She mentioned that once, this is just one little case. The patient had come to her clinic. She explained the IOL that we have to do this and you have to stay admitted for X number of time and all that. So the patient and the husband, they said, look, we need to go back home and bring our things. So she said, okay, she put the device, let them go home and come back. Because it was a close relationship anyway between the doctor and the patient and all. So she did that and everything happened fine. There wasn't any mishap or anything. But, this set me thinking that, internationally, they're talking about, outpatient IOL settings and things like that. So how is that coming up in India? Is it becoming a reality or it will never become a reality?
I don't think it should. I personally have never done it, and I will also prefer not to do it because, see, here we are using some method to induce labor. Say, we know that it's a slow releasing drug delivery system. But I gave you an example of a patient who had tachysystole and who delivered within 2 hours. Right. So if you look at from the medico-legal viewpoint, then it is always better that the patient is admitted. Suppose if we insert it, if the patient goes home, something goes wrong, which is totally unrelated to this, and if there is a fetal distress or fetal demise, then whose responsibility it is? So in the era of medical legality, I think I will certainly not suggest anybody to do it. Let the patient be admitted. You have to be vigilant. You have to keep on monitoring the patient. As I mentioned earlier, once you insert the device, as a standard practice, we have a continuous CTG running for next 45 to 60 minutes. We may not take a printout, but the CTG is going on because that is the time when the chances of tachysystole are high. And then whenever there is tachysystole, we just want to also monitor the fetal heart sound because we don't want the decelerations to take place. Because if there are decelerations, then we really have to reevaluate the patient and then decide whether the insert has to be kept or the insert has to be removed. So I personally have never done it, and I won't even recommend anyone should do it.
Right.
Right. These ideas of induction, home-based induction look very romantic, but they are not practical. Because if something goes wrong, who's going to take the blame? Right. And here, with the kind of medical legal scene that we have, it's better that the patient is admitted. And luckily, our practices are not yet driven by the insurance industries like they are being done in the West, where the patient is sent home within 24 hours of childbirth. So this is something which is not done here.
Right. Okay. Anything else, Nilesh?
No, I think all are covered. All other questions have been covered in the session already. So
Great.
we should now end up.
So thank you very much, sir. And you made my prediction come true. The benefit of having an expert is way beyond the reading from guidelines and articles. So thank you so much, and we look
Thank you. My
forward
pleasure.
to having many more meetings with you, sir.
Sure.
Thank you.
Thank you.
Thank you.
Thank
Thank
you
you so
everyone.
much, sir. Thank you so much. We have successfully completed this virtual CME on the topic of induction of liver and clinical experience with gynoprostone vaginal insert with subject expert Dr. Parag Viniwale, sir. So thank you so much for sparing your time
Thank you.
and remain available and spreading the knowledge to our beloved doctor all over India. So again, from the whole team of Corona, thanking you again.
Sure.
And
Nilesh, if there are any queries, if any of the doctors send you any queries, do share it with me. I will be happy to answer them.
oh, so thank you so much. Thank you so much. So I'm ending the session. And once again, thank you so much for your time, sir.
Thank you. Bye-bye.